Every day, patients in acute distress fall into a lethal administrative gap. They present with severe mental health symptoms entangled with heavy substance use, and they find themselves trapped between two disconnected systems of care. This division is a historical artifact. Psychiatry and addiction services were siloed decades ago, largely dictated by separate funding streams and entirely different origins: medicine and social work. Because of this split, the two disciplines developed completely different cultures. They use different clinical languages, operate on different timelines, and hold conflicting definitions of what recovery actually looks like. This diagram reveals the true statistical overlap. 44% of mental health patients have problematic substance use. Co-occurring conditions are the mathematical norm. On the addiction side, 75% of drug service patients and 85% of alcohol service patients present with significant mental health difficulties. This overlap usually surfaces during an acute crisis. A patient presents to a home treatment team with severe agitation, clear suicidality, and heavy substance intoxication, all happening at exactly the same time. The traditional clinical reflex in these moments is diagnostic categorization. Practitioners immediately attempt to parse the symptoms to figure out which diagnosis came first, trying to find the primary problem. Attempting to isolate the underlying psychiatric illness from the active substance use in the middle of a crisis is impossible. The symptoms are entirely enmeshed, making rigid diagnostic certainty an unhelpful dead end. This reflex feeds the sequential care model fallacy. This is the pervasive, flawed assumption that a patient must achieve total abstinence from substances before a mental health team can effectively treat them. The modern clinical alternative abandons the timeline entirely. Instead, practitioners evaluate the functional relationship between the illness and the substance use to guide their immediate interventions. The separation of mental illness and addiction is an administrative illusion. To save the patients falling through the cracks, home treatment teams must adopt a strict no-wrong door policy and treat the intersecting whole. This matrix illustrates the architecture of dual diagnosis. The top left quadrant shows pattern 1, substance-induced symptoms, where the chemical directly creates the psychiatric presentation. High THC cannabis can directly drive acute psychotic episodes. Stimulants like cocaine produce intense paranoia and psychosis, presenting identically to acute schizophrenia. Conversely, abrupt cessation of central nervous system depressants, like alcohol or benzodiazepines, produces severe perceptual disturbances, extreme anxiety, and dangerous physical instability. For pattern 1 presentations, the directive is clear: hold your diagnostic certainty lightly. Do not attempt to formally diagnose an underlying psychotic illness until after a period of abstinence or stabilization. Furthermore, these withdrawal states are severe medical emergencies. They require immediate escalation using clinical protocols like the CIWA-R, the Clinical Institute Withdrawal Assessment for Alcohol, to measure withdrawal severity and guide safe medical detox. Shifting to the top right quadrant, we find pattern 2, mental illness driving substance use. This reframes active addiction as symptom management. Patients often use GABAergic substances, like alcohol, to manually suppress severe anxiety. Similarly, opioids provide pharmacological numbing in response to profound, intolerable trauma, and patients frequently use stimulants, like cocaine, to self-medicate the extreme lack of focus and energy caused by undiagnosed ADHD or severe depression. Recognizing this leads to the single most important clinical question an assessing practitioner can ask: what does this substance do for you? To understand pattern 2 is to understand the function of the drug. The substance is the fragile shield protecting the patient from an internal storm. Demanding that a patient drop their substance use without first building alternative emotional or pharmacological capacities to weather that storm is completely futile. Removing a maladaptive coping mechanism without replacing it guarantees failure. Approaching the patient with clinical curiosity regarding the substance's function is highly effective. Confrontation fails. Moving to pattern 3, shared underlying causes. Here, the direct causal arrow disappears. Both the mental illness and the substance use grow from the exact same soil. These deep shared vulnerabilities include adverse childhood experiences, complex trauma, extreme poverty, and severe social isolation. Neurodevelopmental conditions like autism and ADHD function in this exact same way. They are concurrent expressions of the patient's underlying environment and physiological vulnerability. The action plan for pattern 3 requires a pivot. Practitioners must shift clinical focus away from strictly pharmacological algorithms and target psychosocial interventions, like housing stabilization and relational continuity. Finally, we reach pattern 4, bidirectional worsening. The illness and the substance use feed directly into one another. For example, depression drives heady drinking. Because alcohol is a depressant, its pharmacology deepens the baseline depression, which then triggers more drinking. We see the same loop with trauma. A hypervigilant patient drinks to force themselves to sleep, but alcohol impairs the brain's emotional processing functions, which worsens the baseline trauma response the next day. The variables lock together and violently accelerate, grinding against the patient's capacity to cope with their mounting distress. Clinical ultimatums, moral judgments, and demands that a patient get clean to get help completely fail against this self-reinforcing distress cycle. The mandatory response to bidirectional cycles is evidence-based harm reduction. This treats the reduction of substance-related damage as a legitimate, life-saving clinical goal. Practical harm reduction steps include providing safe drinking parameters or prescribing nasal naloxone. This rapidly reverses an overdose and directly saves lives. Clinicians accomplish this by utilizing motivational interviewing techniques. This means choosing to roll with resistance and explore a patient's ambivalence, rather than arguing against defenses. Because psychiatric distress and substance use continuously compound one another, maintaining consistent, non-conditional engagement is the only clinical method capable of actually breaking the cycle. To operationalize this, we establish a baseline standard. Because dual diagnosis is the majority presentation, every team member, from Band 3 support workers to consultant psychiatrists, must be competent in basic screening. This interface shows the Audit C, a brief 3-question screen derived from the standard Alcohol Use Disorders Identification Test. It accurately identifies hazardous drinking in under 2 minutes. For broader substance evaluation, clinicians use the DAST-10, the Drug Abuse Screening Test. It relies on 10 simple yes or no questions to accurately evaluate the severity of a patient's drug use over the past 12 months. However, these screens only matter if the resulting documentation is active. Passive clinical notes that simply state patient uses cannabis provide zero actionable medical value to the care team. This visualizes meaningful documentation. The record must detail the substance, dosage, apparent function, and immediate withdrawal risk. Crucially, recording their relationship to change, whether trying to quit or unconcerned, directly informs safety planning and risk assessment. All of this data supports one operational reality: the services must flow together. Practically, a no wrong door policy dictates that referrals to specialized addiction services like REACH or EDAS represent the beginning of integrated care. They are not an exit strategy for the mental health team. We abandon the flawed, warm handoff approach, where a patient is simply passed down the line. We replace it with simultaneous collaborative care, where both the mental health and addiction teams hold the patient concurrently. For dual diagnosis patients, the clinical relationship itself is the primary treatment. Holding steady with a patient through the chaos, without demanding they fix their addiction before you treat their mind, is the ultimate standard of care.